I'm joined now by Professor Salim Abdul Karim, co-chair of the Ministerial Advisory Committee on COVID-19. Good evening, Professor. So when are you getting your COVID vaccine?
Good morning. Good evening, Sally. I'm even disorientated. Good evening, Sally. Good evening to all of the viewers. When we look at the way in which we've decided to distribute and provide vaccines, we've prioritized them, with frontline health workers being the highest priority. Since I myself, don't see patients, and I have my teams do that, and I'm not a frontline worker, I don't qualify under the first phase, so I'll be getting mine when I join the old age queue and get it in the second phase.
I think you also qualify as an essential worker. I wanted to chat to you. We are just through the worst, we know, of the second wave, and you are warning us to start preparing now for the third wave. It is an exhausting thought. What do we need to start doing, though?
So you're quite right, Sally. When we look at the way in which the virus's dynamics, its behavior, we can anticipate that we are likely to see one and probably two waves in the course of this year. And when we look at the way in which it has behaved up to now, we can anticipate that the third wave is likely to occur at the early part of our winter, and then the fourth wave probably in our summer. Now, we would need to vaccinate a very high proportion of our population in order to avoid that, and very few countries are going to be able to do that, if any. So I think we can all anticipate that we will likely see a third wave, and it all depends on the extent to which the virus will create new variants. Because if it creates yet a new variant, as it did in our second wave, then we're likely to see quite a severe third wave. If it doesn't, then we're likely to see a less severe third wave. And we don't really have much experience of third waves from other countries because they're all in the same boat as us. Just one or two have had third waves already.
All right, so you say we're probably going to hit a third wave early winter. Is that beginning of May or beginning of June?
So that's likely to be in June.
In June, right. So we need to start preparing for the third wave. You say that we're hoping not to have a new variant. And I remember when you announced the 501YV2 variant, you said that for months you would sit and talk to Professor Tulio de Oliveira going, nothing much is changing. And then suddenly, boom, there was this new variant that was identified. Do you have any clues as to what makes a new, more transmissible variant suddenly develop, or is it impossible to know?
So there are three ways in which variants develop, and we know this. The first is by jumping species. We saw that in Denmark when workers in the mink farms had the coronavirus, and they transmitted it to the minks. In the minks, the virus mutated, and the minks were then transmitting the virus back to humans, back to the mink farm workers. And the variant that was infecting humans had several mutations. So we know that by jumping species, this is what happens. The second is just by random error, because that's how viruses replicate, and they make mistakes along the way. And that's purely by chance. And then the third, which is the most likely situation in our case, is that it occurs because the virus continues replicating in somebody who has already previously been infected or has been vaccinated. And so the variant that emerges is one that can escape all of that immunity, because if it can't, it'll die. So if it can, it has an advantage.
So it basically learns the way on how to it learns how to escape, essentially. So what is the very latest understanding? Because there's been so much information, I can't order it all. What is the very latest science on how effective these vaccines are going to be against the 501YV2 variant?
So first, let me just clarify. the virus doesn't really have a brain or a memory, so it doesn't actually quite learn. I think what you've used that term, it's actually, it accumulates mutations. So as it replicates, it gets more and more and more mutations. So it's that accumulation process that eventually gives it this ability to escape from the immune responses. So what do we know about the vaccines that, and the variant? Well, the first is we know that there are now 8 vaccines that we have evidence that they are efficacious. And I won't go through the 8, but those are the 8 that we have. Of those 8, 4 of them have published their results. And the other 4, we only have press releases. So the 4 that we have press releases for are Sinovac, J&J, and Novavax. And the 4 where we have published papers, where we have the detailed information, is Moderna, Pfizer, AstraZeneca, and Gamaleya from Russia. So those are the 8 vaccines. When we look at the available evidence, these vaccines are pretty good in preventing clinical COVID-19 that was from the old variants. They're also very good in preventing severe disease, including hospitalization, most of them where we have available data. The problem is we don't know whether they work as well against the 501v2 variant. Now, there are 3 levels of evidence that we use to make a determination as to whether the vaccine works against this variant. The first is a lab test where you make a fake virus that sort of mimics some of the changes we have in the 501v2 variant. And you test it against that, and you see if it can kill the virus. And that's called a pseudovirion assay. That's a low level of evidence. The second is to put a live, real 501v2 virus, grow it up, put the patient's blood in, the vaccinee's blood, and you see if it can kill the real virus. So that's a middle level of evidence. The evidence we really want is what we call clinical evidence. We want to see how it actually performs in real life. And for that, we only really have 2 studies or 2 vaccines that can provide that. The first was the Novavax vaccine, which quite disappointingly showed 89% protection in the UK, but only 49% protection in South Africa. That's deeply concerning to me. The other vaccine is the Johnson & Johnson vaccine. And in that vaccine, the protection in the US was 72%. The protection in Latin America was 66%, and in South Africa was 57%. So it seems that the 501v2 variant reduces the efficacy of the vaccine. But in the case of the Johnson & Johnson vaccine, that reduction was quite small. So that's a bit reassuring, especially because the Johnson & Johnson vaccine was a single dose.
Yeah.
So if you give a second dose, it may do a lot better. So it was a long answer, but it's a complicated question and needed me to give you this kind of detail.
Yeah, sure, I understand. And bearing in mind that our current batch is AstraZeneca, which is going to be rolled out only to healthcare workers from the middle of the month. When do you think we're going to start seeing the vaccine actually having a direct effect on the death toll in South Africa?
We can use the example of Israel right now. So Israel is the country in the world that's doing faster than everyone else in terms of vaccinating its population, partly because they're in a small area and partly because the population is small. They have vaccinated now about 1/3 of their population. And they have, again, focused, like us, on healthcare workers, the elderly, essential workers, and so on. And when they started vaccinating, like us, they were in a wave. And what they have seen is a steady reduction in the hospitalization rates. And it's difficult to tease out how much of that is just the dynamics of the virus and how much of that is vaccine. But certainly what we're seeing is quite promising. that they are now seeing reductions in hospitalizations as high as about a third. So it looks like, at the minimum, the effect that we're likely to see will be on hospitalizations.
All right, so bearing in mind that government says they are hoping to have vaccinated 40 million people by the end of the year, and let's presume a steady progress, by when will we start seeing a decline in deaths, do you think? Are we talking a couple of months, much closer to the end of the year? Impossible to say.
So when I look at it, our priority must be to vaccinate as many people in the first phase and the second phase. In other words, we must vaccinate as many healthcare workers as we can, and we must vaccinate as many people in the categories of elderly, comorbidities, essential workers, and those in congregate settings. So if we can vaccinate just those two groups, that's about 18 to 20 million people. And if we can get a high proportion of those individuals vaccinated by the end of this year, we would have achieved a major accomplishment. It will have, in all likelihood, drastic and substantial impact on hospitalizations and illness. That is even without going to the phase 3, just focusing on phase 1 and 2, because the bulk of our hospitalizations occur from those groups. So if we can impact those groups, they are high priority.
Oh, that's encouraging news indeed. Thank you very much. So if we can get to 20 million vaccinations in those vulnerable groups, we will make significant progress by the end of the year. And also, third wave, it's coming, expected probably June. So get ready. Do not let your guard down. Thank you very much, Professor Salim Abdul Karim.